Hello, and welcome to COVID Vaccine Equity Research Dialogues. I'm Allison Buttenheim, and this is Covered from the Leonard Davis Institute at the University of Pennsylvania. I'm joined by Harold Schmidt from the Department of Medical Ethics and Health Policy at the Perelman School of Medicine here at Penn. And in each Covered episode, we tackle one specific topic under the broad umbrella of equitable rollout of the COVID-19 vaccines. Last time we talked about use of vulnerability indices and similar measures in making allocation decisions. Today, we're talking about vaccine hesitancy, vaccine choice, and outreach. We are delighted to welcome Professor Ruqayyah Yerbi, Professor of Law and member of the Center for Health Law Studies at St. Louis University Law, where she's also co-founder and executive director of the Institute for Healing Justice and Equity. Welcome, Ruqayyah.
Thank you.
So our format here is we talk about a federal sort of CDC, HHS, FDA, Congress issue. Then we pivot to a state or local case study, and we're going to hear about both St. Louis University specifically and Missouri as a state from Ruqayyah, and then recent research finding that's relevant for our conversation about COVID equity. I'm kicking off with the federal beat this time. I had the opportunity a couple of weeks ago to provide testimony for the for the House Science Committee. They had a hearing on vaccine hesitancy, and I made a comment deep into the 3.5-hour hearing about, from a behavioral science perspective, wanting to think carefully about how we present the idea of multiple vaccines being now available for people. From a behavioral science standpoint, we worry a little bit about choice overload or sort of adding cognitive burden to people. And my take is the simplest way to do this rollout is for people to just feel like all these vaccines are fairly equivalent. Any of them is great. I said the best vaccine is the one you can get tomorrow. It's a really vexing health communication, health promotion challenge. In fact, I got some pushback from Representative Mike Garcia, who represents the California 25th, who said, I get what you're saying from a science standpoint, but when I think about my constituents, I think it's very dangerous to message, don't ask questions, don't have fully informed, choice for this. So we now have our third vaccine, the Johnson & Johnson vaccine, was approved for emergency use authorization just a few days ago by the FDA. And now that third vaccine is in our vaccine program. How do we handle that?
And what are some things states should do with the access to the J&J vaccine, which was being tested during the COVID-19 variant?
Yeah, I mean, we have such good phase 3 trial data from the 3 vaccines, but those trials were undertaken in different circumstances, different variants. What we know is that all 3 vaccines are incredibly effective at reducing death, which is good, at reducing hospitalizations. There are some slight differences, which may be due to sort of where and when the trials were run on prevention of mild or moderate disease, but on the whole, 3 really, really strong vaccines. So now a state or a local jurisdiction like Philadelphia has to decide, how does the J&J vaccine enter our existing program that has Pfizer and Moderna being distributed already? Which subgroups do we allocate these doses to? Ruqayyah, can we turn to you and ask about what's going on at St. Louis University and maybe more broadly in Missouri that touches on these issues of sort of hesitancy and outreach?
Here at St. Louis University, we actually participated in the clinical trials of one of the vaccines and now have been identified as one of the sites to distribute it. And so the university has been working with a whole host of faculty and community experts. They are rolling out listening sessions to talk to people just about their hesitancy and doing it not under the guise of focusing on Tuskegee, right? Okay. That it's a broader discussion and a community discussion. They have created materials in different languages, which is so key. And so really working to ensure that they have access to materials that are in their language, as well as trying to do a good job about who gets it first, to really focus on the people who are in direct contact with other people. So people who are cleaning, training, providing food, security officers, to put them at the forefront. They're doing a good job with that, but we have to balance that out with the lack of access to actual vaccine shots from the state. And so the state's failure to equitably allocate vaccine doses may negate the work that SLU is trying to do.
Can you say more about that? What could the state be doing better to support the work you guys are doing individually at SLU?
Well, initially, when we looked at the Missouri state plan, it didn't include a discussion about social vulnerability index, about how they were going to work with communities to ensure that there was a rollout. And so when they began to roll out the vaccine, the discussion was that we'll just do it in a way that people need to make a good faith. Acknowledgement that they fit within the priority, and not actually ensuring that those who were in that priority group were getting it. Furthermore, there's been a lack of distribution of doses appropriately. And so lots of rural areas have gotten shots. In fact, last week they sent 2,000 shots to a community that had 65 people. And so there was a waste of over 1,300 shots, whereas in St. Louis City and St. Louis County, people have to drive over an hour to actually get the doses. They've also put vaccines in places that are not around the St. Louis area, which is predominantly African American. So in Walmarts and places that are outside those communities. And then when they sent it to Kansas City, again, a predominantly urban Black area, the sites that they set up were in predominantly white neighborhoods. And so even if people are working to overcome the hesitancy, you need the actual doses.
And Rukai, you mentioned this community engagement piece that I think many jurisdictions rightly are discovering now, and that has sort of two takes, right? One is, well, to achieve herd immunity, we really need to get everybody vaccinated. So, well, because these people don't trust us and we don't have them engaged, turns out we now need to talk to them. There's a sort of opportunistic, instrumental sense in which that happens. But I think also a really genuine discovery that both now and longer term, this matters to engage communities more fully, right? So on the one hand, it explains why we are in the situation in which we are, that we do need to persuade people. It's just a reflection of that situation. On the other hand, there's also potentially a huge opportunity. Do you think there is one, or am I hallucinating that? And this is really just focused on vaccines?
No, I think it's a wonderful opportunity, particularly here at SLU, and the people who are working with the community are those who have built strong relationships. And so those are the people that are part of the listening sessions. And I think that's so key in any state that is doing it, is using trusted people to build those relationships and to keep those partnerships beyond the vaccine.
Rukaya, now you've described this landscape really well. Now that J&J is going to be arriving, how does that fit in? Do you anticipate opportunities or problems with adding J&J to the program?
To me, I think about it as an opportunity, but as you mentioned, the key is to educate people. When I think about the J&J vaccine, it is even better in the sense of one dose. You can get it out in so many different ways. You can do mobile units, you can go to FQHCs, but as you mentioned, the key is to really educate community. And if you're already having learning sessions and listening sessions, to talk to them, you can hear what their thoughts are, what their needs are, and talk about the ways that the different vaccines actually meet those needs.
So Harold, there really is a unique opportunity to promote equity with this vaccine.
There absolutely is. I mean, as Rukai already also said, right, we can use that much more for mass vaccination sites or very qualified health centers, for primary care practices in rural areas that are also not easily reached. But the problem really is this. On the one hand, we have this concern that this is a vaccine that isn't as good as the other. And on the other hand, we can really use this to especially make the vaccine available to people who don't follow through quite as much as other populations. So what we see from the emerging data, right, is that the second dose in Black and Hispanic persons is much lower than in white people. And that is, because larger shares of these populations are among more disadvantaged populations for whom it's not as easy to schedule another follow-up appointment, for example. So there's a lot of potential in making sure that groups who are more busy will be getting a vaccine more quickly, but also the concern that if we look back at this longer term, if it turns out more of the disadvantaged populations got the vaccine that was perceived to be second best, that may also have potential to ingrain itself into this really concerning history that we have. So as much as possible, we should certainly strive to make both vaccine types available to both people. But I think ultimately we really have to make sure that more vulnerable people for whom it is much more urgent to be vaccinated are able to do so easily in a trusted setting.
That's a great transition point for us. What's going on in the research beat where we can learn from what we know about hesitancy and what we're still learning?
Yeah, because unfortunately with vaccines, it's not a case of you build it and they come, right? As we already talked about, there's the historical stuff, but also many other reasons. And ACIP at the emergency meeting on February 28 presented a really interesting synopsis of what we know about vaccine hesitancy from studies published. And again, everything is moving at warp speed in vaccines. And they updated this guidance 2 days before, right? So this is about as fresh as it gets. But the basic point, what you see on this, these series of bubbles here, is that gray bubbles basically mean it's a one-off survey, and the colorful bubbles means it's repeat surveys in, ideally the same kind of population. And you need to squint a little, but not much, to see that there's a somewhat concerning downward trajectory in these trends of acceptability, right? So a year ago, we had far more people who were willing to take a vaccine than now. You see maybe a slight uptake ever since we had clarity about how effective these vaccines were. But the thing is, this has to be a sales pitch, right? So not everybody wants it. So the most recent data for February is that 46% of people would get a vaccine as soon as it's available, 27% would wait and see, and 18% would definitely not get it, right? So as much as we think these are great vaccines, and as much as we think there's a particularly good opportunity with this J&J vaccine, that's not universal.
Right. So there's a unique potential to use the J&J vaccine in ways that improves equity, mass clinics, general practice, FQHCs, and given a single double shot complexity. But it's an issue that is not helpful for overall situation if worse off get the second best.
Yeah, that's a really important point. So one other study that the ACIP covered was by Nguyen and colleagues, who found that 3 groups in particular were less likely to get vaccinated or less keen on getting one, namely adults with lower income and education, people without health insurance, and non-Hispanic Black adults. And the key point, it comes back to what you just said, Rukaya, right, is that we need to focus our messaging with community outreach and understand what are the specific concerns of these groups, because they're not monolithic. And then there has to be this emphasis on communicating this very complex science that Alison talked about up front, right? That the emphasis here really has to be on, in terms of preventing death and hospitalization, there is no difference. And it's not trivial to really get this across, but absolutely essential to make clear it's not the case that you get a second best here, but something that works for what we need to be concerned about, which is dying from COVID.
Yeah, I think that's our big challenge going forward now. This week, the J&J vaccine rolls out, and all of these issues around equitable allocation of those new doses, this idea of sort of what's best, and I want the best vaccine. What are the ways in which these vaccines are very similar? What are the ways in which they are different? That's what frontline providers and public health programs are going to be tackling. I think that's a great place for us to wrap up. Thank you so much to Professor Rukaya Yerby, Professor of Law and member of the Center for Health Law Studies at SLU Law. I'm Alison Buttenheim, here with Harold Schmidt from the Leonard Davis Institute, and this is Covered. Thanks for joining us. See you next time.